Quanto durerà
quindi non
questa
siamo ancora in
diretta?
diretta. Ma direi, siamo in diretta? Direi 45 minuti, non 30
Ah,
minuti.
no,
È giusto. Fisso il video in cima.
Comunque io finché non vedo la sua vuol dire che non sono online. Welcome to everyone to the second appointment with Chatting with Style. Tonight we will discuss about a surgery case with the Italian. So please come with me and explain.
Good evening, everyone. And we want to introduce you this new approach that we're using for streaming live at first. So as you probably have seen, we have started the live streaming also on YouTube and directly on popdentistry.styleitaliano.org. So we highly encourage you to visit popdentistry.styleitaliano.org, where you will be able to find the live chat. It's a more convenient way to share your questions and to ask the questions, and we definitely focus consider dentistry. That's all. With Facebook, we found out that doesn't like too much surgery. So we definitely want to move to a dedicated player. So that's basically it. And I leave the stage to Dr. Fabio Gorni to go on with this discussion.
Thanks, Diego. It's possible to see also the special guest on the screen.
And we invite the special guest.
So welcome, Arnaldo. I see you on the screen.
welcome to all of you. I'm happy and honored to be here as a special guest. Thank you for inviting me here. It's a big honor. And I'm ready to ask, if you want, all the questions you may ask.
Okay. First, see a video that we recorded around a month ago. So then we will discuss about it.
We're on the screen.
Okay. Now we don't have any audio from the video. Okay. Now I'm presenting to you the case. We don't have any audio because we are online live. But in any case, is a nice case. Is an upper premolar. So that's why we did a CBCT previously. The relationship between the tooth and the anatomical structures is is a nice treatment, a little bit short. The patient got recently restorations on this tooth, so that's why we decided for the surgery and not for the in the axial view, we can see exactly the relationship between the apex and the sinus. So for this reason, we will use the piezosurgery. The first step is the anesthesia. In endodontic surgery, the most important problem is the bleeding control. And if we are using the bleeding, one is a new for anesthesia, and drop by drop we can do a nice injections. In this case, we decided for a papilla preservation flap. The reason is the limited amount of attachment is one of the most frequent flaps that I'm using in the posterior area. This is the kit that we designed with I'm raising the flap. So as you can see, part of the root is completely naked, not for the lesion, but for the natural amount of cortical bone over the roots. And now we will start with the piezosurgery, just to cut a little bit bone and the apex. Using the piezosurgery, one of the advantages of the piezosurgery is the bleeding control during the cutting actions. Especially when we want to remove the soft tissue inside of the osteotomy. With the piezo, I'm design area where the lesion is located, and now just to clean with a little spoon, a surgical spoon, the lesion. First of all, I want to understand exactly if it's possible to detect some portal of exit, but no extra portal of exit. So now I'm doing the resection of the apex. Now we are removing the apex, and now we are removing the soft tissue inside of osteotomy. Really efficient the action of the piezosurgery. Methylene blue just to detect and see exactly the perimeter of the root, and a little bit of ferric sulfate just to finalizing the bleeding control. So now we are ready to see of the root canal system and just to check the situation in terms of endodontic anatomy. All the procedure has been done through the microscope. With the ultrasonic tips, we are preparing the space apically. The correct axis with the ultrasonic tips, and all the time that we are treating two systems in the same root is a good option to connect the two systems. All the time we have an isthmus that connect the systems inside of the root. The rooted prep is finished, so now we can we can fill the space with one of the material that we can use in endodontic surgery. In this case, I'm using Super ABA. All the time that I have to fill a little cavities, or in case of mild bleeding, in terms of bleeding control, I prefer to use Super ABA instead of MTA. That is the other material that usually we are using in endodontic surgery. And the the microsurgery procedure is finished. The suture, and we are ready just to discuss about this case. The surgery is one of the most predictable treatment that we can perform in our office. Maybe later we discuss also about the success rate. Why it's important, Arnaldo, in this case, just to start the discussions. So we are ready. Maybe the first questions or the first discussion is with Arnaldo, one of the most expert guys in endodontic surgery all around the world.
Thank you, Fabio,
Arnaldo?
for the nice compliment. Okay, first of all, I want to congratulate for the beautiful, clean surgery. As always, I know you for many, many years, so I know you are an excellent, not just clinician, but also surgeon. So nice, very nice case, very clean. Because the audio was not with the percentage of vasoconstrictor.
Yes, I understand. It's not so easy to understand the questions, but in any case, usually I'm using the one technology. Why? Because it's the only system that's injection drop by drop in the tissues, and the bleeding control is absolutely much better compared to the normal injections. So that's why in surgery, in general in surgery, I'm using wand. Is not only in surgery, of course, but now we are talking about endodontic surgery, and you know how is important the bleeding control in this kind of surgery.
I
You have to
understand,
try
but
it.
yes, but my question was the kind of anesthesia, the percentage of vasoconstrictor.
No, I don't understand.
Percentage of vasoconstriction.
The percentage. 100,000. I don't use 50,000. So it's 100,000.
1 to 100.
It's articaine 100,000.
Okay. And because of the audio, I didn't understand very well. When you don't have a very excellent, control of the bleeding, you prefer Super EBA. When do you decide Super EBA instead of MTA?
Okay. So the question is Super ABA or MTA.
Yes.
First of all, we don't have any that show us different outcomes between Super ABA and MTA. That is the first step. But when it's possible, I prefer to use MTA, but not all the time. Diego, I'm sorry, I can't see. Okay, not all the time. Or in case of retroprep cavity, one of the problems of the MTA is the washout. And when it's not so easy to compact with a perfect actions, the MTA, and in the small cavity, I prefer to use Super ABA. I'm still using Super ABA in at least 50% of the cases. It's the same for other guys. We already discussed about it, but for example, Jean-Yves Cochet, Bertrand Caillat, Joanie, they are using IRM, still using IRM. So guys, in my opinion, Super ABA is more predictable because you know very well this problem is absolutely the handling of the Super ABA is easy. That's why MTA is a perfect material in selected cases and in the expert hands. This is my opinion.
Well, to be sincere, I think it's a question of personal preference. In my hands, Super ABA is not so easy to handle. It takes time to mix it, and it takes time for setting. In my hands, it's easier to handle MTA, but I see it's a question of personal preference. I've been using Super ABA for many, many years, always. And Super ABA when I'm using MTA is the fact that I cannot see the setting and I cannot do the finishing like I used to do with Super ABA. That's why I was so happy using Super ABA, but now I'm happy and I have good results also with MTA, and it's more biocompatible. I have good control of the bleeding, and so from time to time I also use Super ABA, but my it remains MTA. How is my audio? Can you hear me? I can hear you. I can hear Fabio.
Okay.
Yes, now yes.
Okay. Cost and benefit. For sure, the Super ABA is absolutely not easy to mix it. I totally agree with you. In terms of setting, it takes 2-3 minutes, so it's not a big deal. And in terms of handling in the surgery cavities, bleeding control. If the bleeding control is perfect, MTA is perfect. When the bleeding control is not perfect, we are in trouble with the MTA. It's in my hands, more or less doesn't change anything. But my question get where other guys they did a surgery with the MTA, and when during the resurgery it's impossible to check any kind of obturation inside of the retroprep. It's a question for you, Arnaldo.
Repeat the question because the audio was jumping. You repeat the question. Fabio, can you hear me?
Now, yes.
I didn't hear very well your question. Can you repeat it? Because the audio was not okay.
Okay. Surgery in cases not
Yes.
done by you, where has been used MTA, and in the retrotrap is completely empty
Huh.
for the washout.
Honestly, I didn't have to do another surgery using MTA. On the other hand, it happened to me to do another surgery on my case where I used MTA, and the case was failing for other reasons, not because of the lack of the apical seal, but was failing because the apex was fenestrated outside, not covered by bone. But my MTA was hard as a rock, and I had not difficulty, but using ultrasonic tips, I could remove it quite easily, but the material was still there. So, however, I think it's a question of personal preference. I can hear you now.
Okay. I did a lot of resurgery where I found the cavity completely empty. And in the previous surgery was used MTA. So probably the clinician was not so expert like you, and it was empty. Uh, uh, the MTA is absolutely perfect, but in the non-expert hands, and when the osteotomy bleed, the washout is one of the the most frequent thing that can happen. So cost and benefit. Cost and benefit is both material have a very good outcomes. In terms of outcomes, no difference. In the literature, no difference. So is a personal habit, and in my hands, 50% of the cases with the super ABA and other 50% with the MTA.
Problem, you are absolutely right. You must be expert, and you have to become familiar with the handling of MTA, and be very, very careful with the control of the bleeding. You can't condense MTA when you have a lot of bleeding all around, because it will be washed out for sure.
Yeah.
So
we have another question, Diego.
I hope I said the name correctly. Asked, what about bioceramics?
So another question is on bioceramics, Arnaldo.
Yes.
Okay. I tried several bioceramics. Is for sure is a good materials. Is another good material. In terms of handling, in my hands, I prefer MTA. I don't know Arnaldo, but in my hands, I prefer MTA. I still prefer MTA.
I agree with you. I'm still prefer MTA. And the problem with the other bioceramics, as far as I know, in the literature, there are only articles on experiment on dogs. That's why I always say I cannot make experiment on my patients, and this is the reason why I'm waiting for more literature on human beings, and then I will start using. On the other hand, MTA is also another kind of bioceramic, so I don't see any difference.
Ok, because io ho un ritardo qui.
We-
Ok.
The question is, what do you think about guided surgery?
Another question, Arnaldo, is about the guided surgery. I'm a personal opinion about guided surgery. The guided surgery is a nice opportunity for the beginners just to locate the area for the osteotomy. But if you want to perform all the surgery through the guide, in my opinion, I'm sorry, in my opinion, is not a good experience, because not all our approach all the time is with an angulation from mesial to distal, and the guide could be one of the problems during our action. So if you want to use guided surgery, you can use the guide just at the beginning of the surgery and do a notch on the cortical plate with the burrs, and then you can go for. I'm curious to know your thought, Arnaldo.
I think that I agree with you. In surgery, the most important thing is visibility. So maybe for a beginner, useful. But once you have experience, I don't think we need guided surgery. I think is very important for implants, but not for our surgery. We need to have visibility. We need to raise a flap and expose the bone, expose the root, and have a better control of the entire area. However, this is my opinion. I don't have any experience, of course. So
I totally agree with you. We got another questions?
We've got another question, which is, how do you choose the design of the flap?
The other questions, but Arnaldo can hear you about the question.
Yes, yes.
Maybe
So,
if you
okay, so the other question is about how we design and we decided the design, the flap design. The bleeding control during the procedures is one of the of the step, very important step during the surgery is the flap. If we do a wrong flap, probably we will have also problems during all the procedures, and also difficulties in the bleeding control. The flap has many factors. The depth of the vestibule, the level of attached gingiva, restoration, yes, no, and so on. So that's why the management of the soft tissue is really important. Usually, the Hirschbein-Löbke flap is a submarginal scalloped flap, and the papilla preservation flap. These are the main flap that we can use it.
We got a question.
Another questions?
Directly for Dr. Castellucci, and it
Yes.
is, what do you think upper and lower second molars about the surgery.
Upper and lower second molar. Okay, let me first speak about the upper second molar. Upper second molar is relatively easy as long as the cheek of the patient is retractable. To give you an idea, if Julia Roberts comes to my office for a surgery in the upper second, on the other hand, so sometimes even a first molar can be a problem if the cheek is not retractable enough. And this is the reason why I always want a first visit for the patient. I want him to come to my office, even though he comes from far away, because I need to check something that I cannot check via email, ability of the cheek. That's a very important step. Regarding the same, but the other problem is not only the retractability of the cheek, is the thickness of bone, which is a lot. And I think that in my career, I did surgery only in the second lower molar. Very few cases, maybe 4, 5, 6, not more. And the thickness of bone. Of course, not only I check the retractability of the cheek, today I take a CBCT that will tell me exactly how much bone I have to go across to find the apex.
I agree with Arnaldo. The problem is the retractability of the cheek. That's it. A lot of second lower molar in my career is the same for the upper molar. Of course, when we go in the back, in the jaws, the bone thickness is one of the main problems, but you can check the anatomical situation with the CBCT today. So the CBCT, especially in the jaws, is really important because we can skip very difficult. It's better to check everything before the surgery because during the surgery, if we discover something that is not perfect, we are in trouble. So use the CBCT when you have some dubs. We have a lot of questions, so thanks guys for the questions.
Another one topic of us: how to place the MTA, a small spatula, or a system like MAP1?
When I'm using MTA all the time, I use the MAP systems. That is very useful and very easy to bring material inside of the cavity. At the end of the procedure, most of the time, I use also a little spatula. Kit is the surgery kit designed from our group, and because in my opinion we have to careful press the MTA inside of the cavity. So the washout is our enemy when we are using MTA. So MAP system is perfect.
Then we got
may I say something also?
Arnaldo.
As always, with Fabio, and the MAP system is my favorite carrier that solves so many problems. When I have to fill like a lateral canal, and it's the 90 degrees angle of the needle, it will fill perfectly. And fill not only the main canal, but also the lateral canal, if there is one. The problem is that the dental assistant who mixes the MTA and gives the MAP system must be very careful not to mix it too thick. Otherwise, the needle can be blocked.
ancora un quarto d'ora.
I prefer when the mixing is more a little bit fluid, not too thick, in order not to block the needle. And I always take 2 or 3 map system ready just in case one gets blocked. But it still remains my favorite carrier for MTA. No problem at all.
So,
Another questions?
kind of flap design is better? Is the papilla preservation flap suitable?
In the Pontic area, it depends on the amount of attached gingiva. That's it. But probably in the specific area of the Pontic, we don't need, we don't have any papilla, so probably you can go straight and reach the other relative simple in this case.
Let me say something in favor of the submarginal flap design, because of course in the literature you can find everything you want. Many articles criticize the submarginal flap because of the textbook. I published so many cases with the submarginal gingiva flap design, and there is no scar at all. So if I have attached gingiva, I prefer the submarginal flap, especially if I have bridges and crowns and aesthetic problems, and I don't want to have any aesthetic problem with the recession, of course. So anytime I have enough papilla preservation, but when I have enough attached gingiva, and if I am very careful with the repositioning and suturing and early removal of the suture, I promise I have no scar at all.
Totally agree. Same experience for me. No scar at all. No scar at all. And when the submarginal is the best solution if it's possible, of course. Another question?
Another question, this time about, well, let's say ergonomics. Do you suggest to have a team of 2 nurses for a better result, and does it impact, does it change the outcome in your opinion?
In an easy case, we can use just 1 nurse. In a difficult case, 2 nurses. Arnaldo used 2 nurses all the time.
May I say I'm very, very spoiled, I admit. But I have 2 dental assistants always. One has the assistant scope and is only suctioning the bud, nothing else. The other one on my right-hand side, she is the one who mixes MTA and gives me the map system. But in difficult cases, like a lower in the distal, 2 canals and the isthmus in the mesial, I don't want to waste and wait too much time waiting for the map system that comes to me. So I have 3 dental assistants. One collects the map system from the first one and gives it to me. Then she puts the plugger in my hands, and when I'm plugging, she already has the next map system and gives me the next map system. So one after the other, one after that, we don't waste any single second. But I'm spoiled, I know.
Arnaldo is a rich dentist, so that's why I can use 3 nurses.
Yes, sure.
Another
Okay.
question, patient's medical history. Do you take some particular resolution in patients
with a systemic histories, or in any case with some disease, general disease? Yes, we prepare the patient with some antibiotics, but is rare. Is not is not a normal procedures. There's another question.
Yeah. What about apical resection?
What about apical resection? It is one of the most important steps of the surgery, and usually the big mistakes happens during the apical resection, because for the apical resections we need a lot of knowledge in terms of endodontic anatomy. Why
Here,
through an osteotomy is not a surgery treatment, but is an endodontic treatment through a surgery access. So that's why the knowledge, the endodontic knowledge about anatomy are very, very important. And that's why the apical resections is so important, very, very important for the terminal outcomes, for the final outcomes, very, very important.
Keep asking. Keep asking.
About the angle of resection is a huge is a huge topic, and soon I will publish something about the apical resections. I don't think that we can discuss about the apical resection and about the bevel in a couple of minutes, but in my anything in terms of outcomes, zero, and we are ready to publish an article about that. So that's why it's a very, very good interesting topics, but we need time to discuss it. Arnaldo?
yes, I try as much as possible a section perpendicular, not too much bevel, like we used to do years ago. And the reason is, if you make a very steep bevel, how do you seal the dentinal tubules on the palatal side of the bevel? And also, let me say something more. I never intentionally too much could be too little. So I always try to isolate the apex from the granulation tissue, and then I put the liniment burr on top of the apex, and then I shave the apex until I see the canal exactly in the center. That means that I have enough denting to prepare my retro prep. Or if I have two canals, I want to see enough denting also too. That's why I keep shaving and beveling or removing the apex until I see enough denting palatal to MB2. So I don't decide in advance how many millimeters I will remove. It depends on the anatomy. That's why, as Fabio said, this specialty and this dentist, not the oral surgeon and maxillofacial surgeons, because nobody knows the root canal anatomy and the endodontic anatomy better than us, endodontists. Okay, so as Fabio said, this is not just for just surgery made for endodontic reasons. This is an endodontic treatment made through a surgical flap. So it's a question of different mentality.
I totally agree with Arnaldo, and when it's me too, I try to cut the root 90 degrees to the long axis, but I repeat, is a very interesting topics, and we have to discuss with in a different situation, in a different not on the chat. Of time, because we have to discuss about the dentinal tubules, but also how deep is our root and prep. So many years ago, when we used the straight end piece, and also for the retro prep, and just amalgam like retro fill materials was so difficult side of the root, so following the main axis. With the ultrasonic tips is completely different. That's why also the role of the bevel is a bit different, but soon we will come back on these topics also on our group. Is another question, the last question, because after that we have to discuss a little bit about
suture when remove stitches.
Arnaldo, please reply to these questions.
Repeat the question, please.
Okay. What about suture in general, and after how many you remove the stitches?
This is a question for me?
Please reply to the questions.
Okay. Well, first of all, I do the suturing under the microscope, always, because I want to be very, very precise. So that if the repositioning is not just fine, but must be perfect, so that the healing will be my primary intention, then we know that epithelium travels at the speed of 1 millimeter in 24 hours. That means that after 24 hours, the incision is already sealed, okay? And if it is sealed by the epithelium, just the epithelium after 24 hours, but is closed, and then there is no reason to leave the suture any longer. So I remove the suture after 24 hours, after 1 week, like we used to do many years ago. And there are articles explaining why we can and we should remove the suture so early.
Okay, I have a little bit different opinion about that, but also not so soon, but soon. Now, I want to ask to our special guest something about this opera. Do you know, Arnaldo, this book?
Yes, I know.
Do you know?
It took me a lot of time and a lot of energy.
It's a beautiful cases come from me. And
Yes.
oh, I opened the book on the wrong page.
You are in the flap design, in the papilla presentation.
Is an incredible opera. I suggest to all of you to take it and to read it carefully, this book. Arnaldo did a really, really interesting opera. It's a beautiful book, really, really beautiful. Is the English version. So look at the pictures. Look at the pictures that are beautiful. So please, Arnaldo, explain to us something about the book.
It took me about 2 years, or 2 months of August mainly, and then some weeks during the winter. So I had to say thanks to my wife, first of all. Second, inside the book, as you probably have noticed, there are several QR codes. That means that you can, with your iPhone, you can take the picture of the QR code. I have a total of 51 videos inside, from incision to the suture to the removal of the suture. Every single step is documented with video. And I want to say something more about the piezo surgery, because I'm very happy that in the chapter 9 is described a different technique to reach the apex, the chapter written by my friend from Toronto, Yossi Namias, and they are using, of course, the piezoelectric surgery. And I want to make a comment on the piezoelectric surgery because something very, very useful for us. Just to give you an idea, also, when I have to do the surgery very close or inside contact with the membrane, then I use the piezo surgery. I had a case where the overfilling material was a piece of gutta percha and sealer right on top of the mental nerve. And not only I removed the gutta percha point, but I also, with the piezoelectric surgery, I cleaned the surface of the nerve from the debris of sealer without damaging the nerve. Because the piezo surgery is very efficient in dentin and cementum, but is absolutely inert in contact with the soft tissue. That's why it's so important for us.
Thanks, Arnaldo, especially for the book. Is a fantastic, fantastic opera and absolutely useful for all of us.
Again, and I'm happy to inform you that in a few weeks there will be the Italian meeting of the Italian Endo Society, and the Italian version will be ready. And I know that the editor is also working on the Spanish edition. So pretty soon also it will be translated into Spanish.
Fantastic news. Okay.
Thank you.
Thanks to the special guest Arnaldo, and I hope to see you again soon on Pop Dentistry and on Street Italian Endodontics. Stay tuned.
Thank you, Fabio. Thank you for inviting me, and bye-bye to everybody.